Wanted to thank on behalf of our panelists here today and myself for Boston Scientific for sponsoring this lunch program, and we hope to make it interactive. And so if any of the audience members have any questions, clarifications, anything that you want us to discuss, please feel free to come to either one of these mics and we'd be happy to do so. So the topic of today's lunch symposium is From Complexity to Clarity, Navigating C2-C6 Disease. So I wanted to start off to talk about the right treatment for the right patient. So here are my disclosures. Just as a little bit of a background, we all know that chronic venous insufficiency is really a clinical challenge. It affects 190 million people worldwide. And in the US, approximately 30 million people are affected from chronic venous insufficiency. It's a huge healthcare burden. An estimated $150 to $1 billion of US expenditures are attributed to chronic venous insufficiency. Especially burdensome is really how to treat ulcers as well. In addition, about 2 million patients with chronic venous insufficiency seek treatment each year, but only about 447,000 patients receive treatment for their chronic venous insufficiency. It's interesting why there's such a delay in care, because patients live with chronic venous insufficiency on average for about 35 years prior to seeking treatment. However, it's twice as prevalent as coronary artery disease and 5 times as prevalent than PAD. So I wanted to sort of discuss, especially in my practice, I practice in Washington, D.C. at MedStar Georgetown University Hospital, where there's a large wound center that we work with as sort of a multidisciplinary team of podiatrists, vascular surgeons such as myself, plastic surgeons, rheumatologists. We see a lot of C6 disease patients. However, I treat anywhere from sort of patients who come in with very superficial telangiectasias to all the way from C2 to C5. And with each one of these patients, I really like to tailor my treatment plan for them. Obviously, when obtaining sort of their history and physical, I really do focus on a lot of their social history, sort of their social economic constraints, their medical history, about whether they've had a DVT before, how long that they've had their symptoms, their allergies. I think that this is really important when you're tailoring treatment options for patients with chronic venous insufficiency, as this is something that is really important, especially in some of the endovenous catheter-based closure options. As well, I think one of the main things that we really need to discuss with our patients is patient expectations. And again, as I mentioned before, where I practice, we have patients of sort of different backgrounds, different demographics, different social economic constraints. There are people who don't have insurance, and I treat them pro bono, to people who do self-pay, even if it's for endovenous catheter-based therapies or non-thermal foam sclerotherapy. So I have a huge gamut, and with each one of them, I like to tailor my treatment plan so it's very individualized. So this one patient here that I treated was a 45-year-old male. He had a history of varicose veins since his early 20s. He had no history of DVT, but he did have a history of a right medial leg ulcer, so he was a CEAP5 patient. He had a history of right GSV stripping in his late 30s. And he does wear compression stockings, although he does not, it's not really recent, I would say. They seemed quite old and quite ineffective. So interestingly, this patient came in with complaints of sort of just pain in the leg, heaviness, achiness, and especially at the end of the day. So his chronic venous insufficiency really progressed as he sort of told me how he initially presented to the point where he was presenting now. And again, had these ulcers as well. He was a single father of 2. He had a standing profession as a security guard. It turns out that he doesn't do a lot of standing. He works at night, so he actually does a lot of sitting and minimal walking. And he has difficulty missing work, takes care of his children during the day, and then he goes at night to work as a security guard. So Here's his venous duplex. Sorry if it's a little bit small, but he had no evidence of deep or superficial vein thrombosis. He did have a significant amount of deep venous reflux. And as you can also see, he had greater than half second of reflux identified throughout all segments of the great saphenous vein. It was tortuous and at some portions extrafascial. Small saphenous vein, anterior accessory vein were also tortuous, and the mid and distal calf perforator vein were also refluxing. Again, I wanted to mention that the anterior accessory vein was also tortuous, mildly tortuous. So after discussion with him, because of the tortuosity and the number of varicosities that were coming from the GSV, especially in the below knee section, and then as well, he had a lot of varicosities coming from the tortuous right AASV, we decided to offer him closure with Varithena. And if needed, we would go back and do the right SSV with RFA. And as you can see here, I just wanted to point out how abundant his varicosities were. As you can see on the left hand of the screen, you can really see that it wasn't just around one area that we really needed to treat. I really needed all that foam to go into all of those varicosities surrounding the ASV and the GSV. So this is sort of where we started here, and the true GSV, this is not the true GSV, but a lot of the varicosities. And once we started using the foam and accessing this area here to get to the GSV, you can see that the foam really, with compression, really closed off all those varicosities. And you can sort of see that bright white that you see on the ultrasound going through each of the veins. And so at the end of it, when you scan, you can really see the Varithena as sort of this sort of white linear area that you know that has treated the vein and sort of shrunk it up, which means that it was a very successful closure techniques. So in this patient, we did both the right ASV and the right GSV at the same time. You could treat it at different times, but given the patient's sort of social economic constraints, I was able to split up the amount of Varithena to be used in between the right GSV and the right AASV. He went back to work that night. He did get better compression for himself, and then he ace bandaged the top portion while he went back to work that night. He did not take any time off of work, and there was no need for him to have tumescence just because of the fact that it was not a thermal technique. So as you can see here, sorry for the lighting of the different color here, but you can see that his varicosities that were pretty big were receding, and as well, he felt better. I don't think he necessarily cared about how his varicosities looked, but he said that his leg felt a lot better, a lot less heavy, a lot less swollen, which could in part be part of his new compression stockings as well. But he said that the discoloration around his ankle was also getting much better with compression as well, and the Varithena. So other techniques that I did consider really was doing sort of the high ligation and stripping with maybe concomitant stab phlebectomy, but for him, I tailored the fact that to use the Varithena because of the fact that he really could not take time off of work. Like, this was a major deal for him, is that he could not do that. And of course, periprocedurally, it was really easy for him to receive this care as well. The recovery was quite simple. Again, he showed up at 4 and he was able to go to work shortly thereafter. As well, I think in him, right near the previous ulcer site, there was a lot of hyperpigmentation and woodiness. Again, probably improved with his new compression therapy, but the skin integrity in that area was a little bit compromised as well. And doing stab phlebectomies probably wasn't as ideal for him, and that's why I chose the Varithena. Could we have just used plain old sclerotherapy? I think that that's an option as well for him, but I think it would have taken multiple visits for him to have the effect that the Varithena microfoam was able to achieve. And again, there's limited efficacy with sort of the plain old sclerotherapy, I think, than in comparison to sort of the strong Varithena microfoam. So this is just one case that I wanted to present about making sure that you tailor sort of what you have in your armamentarium, not just the anatomical features or sort of what the patient expects, but being able to really take into account all of what really the patient needs, not just what you see in front of you. So I'm happy to take questions now, or maybe we'll take questions after. And as well, some of the official Varithena commentary we have here from Boston side. And Dr. Shao, did you want to come up and share us your case as well?
Okay, thank you, Dr. Kiguchi, and good afternoon, everyone. I'll talk about the role of Varithena in a contemporary vein practice. And like Dr. Kiguchi, I practice in a hospital-based setting. About half of my work is arterial disease, and the other half is venous. So we see a lot of venous patients, both in our office, but also in the hospital-based wound care center. These are my disclosures. So I'll highlight, we'll go over two cases treated with Varithena, highlighting procedural steps and some technical tips and tricks. And lastly, I'll talk about the VIEW-VLU trial, which evaluated Varithena for treatment of venous leg ulcers or C6 disease. So our first patient's an 87-year-old male who presented to me in the wound care center with a troubling episode of bleeding from left medial ankle varicosities. He said he had to call 911. There was a profuse amount of blood. They brought him to the ER where they finally stopped the bleeding with some stitches. He complains of the typical venous insufficiency symptoms of leg discomfort and fatigue with prolonged standing. And he's quite active for his age. He walks 8,000 steps per day, which is a lot better than me. And when I asked for permission to present his case for this meeting, he said, make sure you tell him that I was born in 1936. So he has the typical skin changes with hyperpigmentation suggestive of chronic venous stasis. And the bleeding point was this this eschar at the medial malleolus. You can't see the bulging varicosities when he's laying supine, but when he stands up, you can see them bulging out. And his venous duplex showed long segment reflux in the great saphenous vein from distal thigh to the ankle. And we chose to treat him with Varithena among all of the available options in our toolkit for several reasons. Our main goal was to prevent recurrent bleeding from these ankle varicosities. We wanted to avoid the risk of thermal nerve injury with other treatment modalities. And we wanted to be able to treat both the truncal reflux and the tributary reflux leading up to the bleeding point in a single procedure. And so we brought him to our hospital-based ambulatory surgery center. I would say the first, the important step is to really elevate the leg for two reasons. Number one, this really allows you to empty the venous system, enabling you to use a much smaller amount of foam for the procedure. And it should, number two, increase efficacy as well for closure. We got ultrasound-guided micropuncture wire access. And here we're advancing a 4 French micropuncture sheath. And I should mention that you may want to get access with the legs down first with the veins distended to make it easy, but once you have stable access, then elevate the legs. And sometimes to really empty the venous system. And sometimes I'll even use my hands to manually compress the GSV along the medial calf and thigh to really make the vein tiny so that it minimizes the amount of foam that you can use. Sometimes we'll just use maybe 6 or 8 mLs to close the entire GSV from saphenofemoral junction to the ankle. Next, you want to generate the foam once you have access. It's important to purge the first 3 to 5 mLs back into the canister to get rid of any air in the system. Once you draw up the foam, it's important to use it within 75 seconds of generation before the foam breaks down. Now, keep in mind that this foam is much more potent and lasts much longer than physician compounded foam, so you have some time. Once you have the access, there I'll pull it back a little bit just to get the distal GSV. And you want to inject slowly, about a cc per second. And as you can see, our RVT is following the foam up the great saphenous vein.
That should pass pretty quickly.
What's that?
And then I think maybe hold pressure is the near there.
Oh, sorry. Thank you. Embarrassing, but anyway, as you can see, our RVT is following the foam traveling up the GSV, and you want to follow that foam up to the saphenofemoral junction, where you hold pressure for 3 minutes to allow vasospasm to occur. In this case, we held pressure at the distal thigh because I wanted to leave the competent segment of GSV alone in the upper thigh. After treatment, you need to apply compression, and compliance with compression is really critical for efficacy and success. Oftentimes it may be difficult in a patient who has obese body habitus to really wrap the leg, but the Varithena kit comes with these tubular structures that you can apply along the treated vein to allow for focal compression over the exact vein that you treat. And we instruct the patients to walk immediately after the procedure, several laps around the nurse's station. It's advised to continue with continuous compression for at least 48 hours. In our practice, they'll continue for 72 hours until their post-procedure ultrasound. And then we instruct them to wear compression stockings during the daytime for the next 2 weeks thereafter, and no heavy exercise for 1 week. So what are the advantages of Varithena for this case? Number one, it directly treats the terminal refluxing tributaries, really feeding the bleeding point itself. Number two, you can treat both the tributary reflux and the axial reflux in a single procedure, so it is convenient for the patient and it's efficient for you. Number three, this is all distal GSV disease, so it's this non-thermal ablation is preferred so that you avoid the risk of thermal nerve injury. And you can see that in this patient with really thin legs, the GSV was quite close to the skin surface, so I would worry about, with thermal ablation, getting enough tumescent fluid around the vein and the risk of thermal nerve injury with either laser or radiofrequency. And as you can see from the video, there's really minimal procedural discomfort. And oftentimes I showed the video to my patients in the office just to show them that it's a procedure that's really no big deal. A lot of patients have anxiety with medical procedures, but really there's no sedation or pain medication required. And the microfoam is quickly absorbed. There's no foreign body left behind in contrast to some other treatment modalities. Our second case, this is a 93-year-old female who presented to us in the wound care center. She's a retired nun. She presents with a recurrent ankle venous stasis ulcer. She had a recent admission for cellulitis requiring IV antibiotics, and we've had her with a lymphedema pump for several years to treat chronic edema. She's had chronic recurrent ulcers in both legs since at least 4 years ago, and she's undergone previous truncal ablation of the bilateral GSV and the right anterior accessory saphenous vein. Her right ankle ulcer ultimately healed after venous ablation very quickly, but she's had recurrence of ulcers in both legs over the years, typically taking months to heal. And most recently, she presented again to us in May with a recurrent right ankle ulcer. Her venous duplex ultrasound that we did in the wound care center showed that the proximal GSV actually remained closed in the thigh, but she had recanalization of the distal segment below the knee, partial recanalization, I should say, with diffuse long segment reflux. And the ultrasound tech also noted a persistent tributaries extending to the ulcer bed itself. So again, we chose to treat her with Varithena as the optimal treatment modality. Our goal here is to speed ulcer healing, but also to reduce her risk of future recurrence. And her recurrence was likely due to that recanalization of the below knee segment of the GSV after previous ablation. The recanalized segment had a lot of webbing. Sometimes you'll see this. And we had concerns that we would not be able to pass a catheter up this area, whether it was radiofrequency or glue. And the recurrence was also likely due to persistent terminal reflux near the ulcer bed itself, directly going to the ulcer. And so you can see that when she initially presented, this was her wound, and her wound languished for about 2 months, even despite aggressive local wound care and compression in our wound care center, until we finally treated her with Varithena of the GSV and the tributaries. And within 10 days, her ulcer healed, and there was a marked reduction in peri-wound skin inflammation as well, as you can see. So what are the advantages of Varithena in this case? First, it's ideal for treating C6 disease because it directly targets the terminal refluxing tributaries feeding the ulcer bed itself. It allows treatment to the most distal point at the ankle with zero risk of thermal nerve injury. It's really ideal for recurrent VLUs. In this patient's case, her recurrence was due to recanalization of previously ablated truncal GSV. And also persistent distal reflux in the tributaries coming off of it. We could treat this in one procedure, and so this is efficient for you in your practice if you're busy, and also convenient for the patient because it's not coming back and forth for multiple procedures. And this shows the versatility of Varithena in being able to treat both the axial reflux that's not really amenable to catheter ablation with partial recanalization, and being able to treat the tortuous tributaries as well in one setting. And this brings me to, this case kind of echoes what we found in a recent clinical trial evaluating Varithena to treat venous leg ulcers, the VIEW-VLU trial. This was a multi-center trial across 14 sites across the US and Canada. We enrolled 76 patients with 80 ulcers. Patients had to have documented GSV and anterior accessory incompetence. We excluded patients who, in the opinion of the investigator, would likely heal within a few weeks. At baseline, patient demographics, the mean ulcer age was 8 months at presentation, so these were very long-standing wounds. And the mean BMI of these patients was 36, so many of them were quite obese. A quarter of the wounds were actually circumferential. So taken as a whole, this was a very challenging population of wounds and patients to treat. And Varithena treatment actually resulted in healing of more than half the wounds, 54% by 12 weeks, with a median healing time of 89 days. And by 6 months, 75% of these wounds were healed, which is quite impressive. And out to 1 year, we saw improvement in pain scores and quality of life scores. And so I'll highlight this further in another talk on Thursday at the wound care session. But in conclusion, Varithena really shows promise in treating these recalcitrant venous leg ulcers in a challenging real-world patient population, patients that we see every day in our wound care centers. Thank you.
Thank you, Dr. Shao. I just wanted to ask a couple questions, and of course, we'll entertain any, and please use the mics right here. In your first case, you said that you put pressure at the mid-thigh because the proximal portion was still competent. I have one question, or two questions, two parts. The first one would be, how do you get insurance approval for something that does not have saphenofemoral junction incompetence or proximal thigh, as they always ask for? And two, why not just treat the entire GSV? Why leave the competent portion, as most people just put pressure right at the saphenofemoral junction and treat the entire GSV?
Both great questions. First, I can't remember the patient's insurance carrier, but it's very insurance carrier specific at our location. I can't remember which national carrier requires saphenofemoral junction reflux, but not all of them do. I think as long as you're ablating truncal vein, you should get covered for the CPT code 36465. I can't recall if this patient was Medicare or not. I don't believe that Medicare requires junctional reflux. The second question is a great question. I did debate whether I should just ablate the entire GSV itself. I'm not sure there's a right or wrong answer. I just felt like the upper thigh GSV was still competent in doing its job, and perhaps maybe leaving it alone would be a good option. But I might be wrong. She might come back with reflux, in a year in the upper thigh segment, and I might regret not treating the whole thing. So I think it's a good debate.
And then you can treat it again with some more Varithena.
Yeah, exactly.
But my other question was your second case. How do you mentioned that the below knee GSV recanalized, but it was treated before with RFA, correct?
It was. Actually, it's interesting. I didn't put all the details in there, but she was initially treated with cyanoacrylate glue. That recurred, and then I think we followed up treatment with radiofrequency ablation, and that recurred again. And so there was all this webbing within the lumen of the vein where we felt like it would be difficult to get catheter back up into that vein.
Yeah, it's interesting because I see a lot of patients who have had radiofrequency ablation, and they start sort of at the 1/3 of the proximal calf. And then later on, that remaining segment, for most patients, is not really a big deal. But for many of the patients who come in with the CEAP5, CEAP6 disease, often that great saphenous vein is really the issue at hand. And so using Varithena in that remaining or remnant GSV, I think, is really something that helps these patients. But I didn't know how you knew it was a recanalization of that segment. It might just be that was what was left after the proximal portion.
I only know because I was the one who treated her previously with RF and cyanoacrylate glue. But yeah, I agree with you 100%. I feel like a lot of these difficult to heal ulcers that are either recurrent or persistent is really due to the distal reflux. It's not really the proximal reflux in the upper thigh, but it's this persistent distal reflux in the GSV below the knee, and also the tributaries that lead up to the ulcer bed itself.
That's great. We have a question from the audience.
Yeah, hi, Kent Webb, vascular surgery from Texas. And 2 questions. What are you all doing about the trapped coagulum for some of those big varicosities, which in my experience takes a long time to resolve, and patients tend to get a chemical phlebitis there. Are you bringing them back to drain it? Or how do you all manage that for those real big surface varicose veins?
Yeah, excellent question. We do deal with that, and in my practice, if they have really large visible varicosity on the skin surface and I'm concerned about pain and retained coagulum, I'll schedule a visit at the post-op ultrasound 3 days later to evacuate it. And I found that sometimes it's difficult I've tried to aspirate it with an 18-gauge large bore needle, but it's too organized sometimes. And so what I'll do is numb up the skin and make little nicks with an 11 blade and kind of express it out. It's a little bit uncomfortable sometimes when you do that, but they ultimately have a great both physical symptom improvement result with less inflammation, and also a much better cosmetic result with that.
And then the other question was, I've heard reports of some people doing thermal ablation for the proximal GSV to the knee, and then at the same session using Varithena for the distal and tributaries. And do you have any experience with that? They say insurance companies are covering that, but are you all using that in a single session, or?
I wouldn't treat it in a single session. I think I think you run the risk of over-treatment, because you can treat the entire GSV with Varithena, so why would you use 2 modalities? And I think I would not recommend that approach, because I think you open yourself to an audit for over-treatment. I don't know how the rest of the panel
I have not
feels.
done that, but I have brought them back if there's residual distal to close that distal segment. But I was just curious because some people are reporting they're doing all that in the same session.
I agree. I think that this goes back to sort of the tailoring the patient's disease versus sort of what their insurance covers and what the expectations are. Especially for many of my patients, they really don't have coverage for everything. So if they come in and they're maybe a C4 at most, and their main complaint really is just heaviness and achiness, I may just do a thermal ablation. But if they're CEAP6 patients and I really want to treat the entire length of the offending refluxing vein, get that below knee segment, which often does really contribute to that venous hypertension that gets that ulcer, I would offer that patient just the entire length of the saphenous vein to treat it with a non-thermal sort of a modality or Varithena.
And then just my last quick question. What are you doing for the EFITs? If you get a rare EFIT, how are you treating those? Are you just observing those? Aspirin, full anticoagulation? What's your approach?
Oh, I think Dr. Satwah also had a comment about the previous question too.
Oh, no, thank you. A couple of things. So first, to answer the question about the retained coagulum, yes, that was one of the main adverse reactions under the VANISH-1 and VANISH-2 trials. And so I think the key thing to understand is that while retained coagulum is potentially, an issue with using Varithena, we can also think ahead. So what I typically do in my practice is if I have a patient with a lot of varicosities that are bulging, I'll take a 16 gauge and I'll lance or break the varicosity ahead of time and just drain it a little bit to decrease the pressure, thereby decreasing any potential retained coagulum afterwards. What it also does is it decreases the amount of phlebectomies that I need to do as well. And then I tailor the treatment with adding a little Varithena afterwards into the segments that are left behind. To answer the question about treating the GSV with thermal and non-thermal, I agree with the panel. I think it also depends on obviously your insurance companies, but let's remember that Varithena is indicated for the incompetent GSV system. You can treat the entire GSV with Varithena. And so there really should not be a reason why you're double treating the GSV, in my opinion.
I agree, yeah, 100%. And then we may all have different ways of dealing with EHIT or common femoral thrombus vein extension. In our practice, we will anticoagulate with oral anticoagulant like Xarelto or Eliquis for 3 weeks and then bring them back for a repeat ultrasound. I find that if I bring them back after 1 week, it hasn't changed much, so I give them 3 weeks with like free samples, and then usually it almost invariably has retracted. I don't know how the rest of the panel feels.
Yeah, no, I think that's very similar to what I do. I think that one should not be gun shy about using Varithena if you're concerned about DVTs. The majority of the DVTs that are found in these patients are typically tibial DVTs, tibial vein DVTs below the knee, and majority of them are asymptomatic. But if these patients do come back with symptomatic tibial vein DVT, I follow the American College of Chest Physicians guidelines in that I'll either do a surveillance ultrasound, bring them back every couple weeks, or if they're very symptomatic, we can add a baby aspirin to their regimen. If they're already on an aspirin and they're very symptomatic, then I do direct oral anticoagulant therapy of your choice, whether it's Xarelto or Eliquis.
I agree with that. My highest rate of DVTs are the tibial DVTs, and maybe it's a misperforator or whatnot that I didn't hold pressure on. But again, I usually observe those, especially in the posterior tibials.
Yeah, I usually say that if you have never experienced a tibial vein DVT using Varithena, you just haven't done enough yet.
Yeah, sorry, to answer the tibial DVT question, I end up actually anticoagulating them for 3 months, but I actually don't lose any sleep over it. They're all asymptomatic. The patients are still quite happy with the results. If there's any problems with bleeding, like, heavy menstrual cycles, we can discuss it and I might hold it, but I end up treating it with 3 months as a standard DVT just to prevent any risk of proximal extension.
Sounds good.
Thank you.
Well, great. I had a quick question. My name is Ed Boyle from Oregon. In your trial, you didn't treat small saphenous vein or perforators, and I know that might not be indicated with Varithena, but in your clinical practice, do you do more than one procedure for these folks to kind of follow that up and maybe get more healing?
As Dr. Kiguchi said, it's really kind of tailored to the patient's anatomy and clinical scenario. Small saphenous reflux isn't really on label for Varithena, so I can't really comment about that here. But the trial, the VIEW-VLU trial, had a high incidence of perforator incompetence. I want to say like 35 or 40%, and a high number of small saphenous incompetence that was not treated, and despite that, it still achieved a pretty significant healing response, even without treating that disease. So you might think that if that were ultimately treated, they might even have better healing.
Great. As we call Dr. Satwah up, we'll take our last question.
Tom Parsup, Orange County, California. When you're applying Varithena, of course, after you drain the leg and the venous system, do you manually block the saphenofemoral junction? And if you do, how long do you do that while you're injecting the Varithena?
So I typically, we follow the foam up as it travels, as you saw in the ultrasound, until it's within a few centimeters or 5 centimeters from the junction, and then we'll hold for 3 minutes, and then rescan. And how about the rest of the panel?
3 minutes is what I do.
Yeah, 3 to 5 minutes. The larger the GSV, the longer I stay closer to 5, but three minutes for the majority of the GSVs. Yeah.
Thank you.
Great questions. Thank you.
So Dr. Satwah's up next.
All right, great questions, everybody. And please know that we'll also have plenty of time after this case to ask more questions if anything else pops up. I also want to take this opportunity to let you know that Boston Scientific has a wonderful amount of resources for you. I know there's a lot of questions about reimbursement sometimes, and we all know that it really depends on your local carrier. So we actually have one of the gurus of reimbursement when it comes to Varithena in the room, Mr. Dirk. If you just stand up real quick. Mr. Dirk is here, and he will be happy. Yes, Dirk. He's very resourceful and helpful in allowing us to learn about reimbursements, and he'll be very happy in his team to guide you through that process as you're learning to use Varithena. Just by show of hands, how many people do use Varithena currently in their practice? Okay, good. So roughly about a quarter of the room. And so I just want to make sure that I'm standing here as a presenter at a national stage. I want you to know that this is a journey. This is an evolution for me when it comes to using Varithena. I just didn't start using Varithena from day one. And I like to share that with you because I think it's important to understand when Varithena was first introduced to me, it was introduced to me as polydocanol. And I said, well, I hate to be the bearer of bad news, guys, but polydocanol has been around for a very long time, right? But what they said was that, hey, we have this proprietary canister system, the bubbles are uniform, it increases the stability of the compound, increases closure rates in the veins. I still wasn't buying it. So what really kind of pushed me to believe in this product was they said, you know what are you doing for your distal calf GSVs that are refluxing? I said, well, there's not a whole lot because I had one unfortunate neuropathy due to thermal injury in my life, and that was one too many. So I was very gun shy when it came to distal calf GSVs. And so what I was doing was just physician compounded foam, like most of us were doing. And the next question was, what are your closure rates? And, being the pompous physician that I was, I said, 100%, come on. It always closes, right? But when I went back and looked at it, my data showed that it was not 100%. It was closer to 60 to 70%. And so they said, well, what are your thoughts on using Varithena in these type of patients? So I gave it a try. And after 6 months of using it and looking at my data, my closure rates went up above 96%. And so that's when it really, caught on to me that, hey, this stuff really works. As I became more comfortable using it in the distal calf GSVs, one of the cases that Dr. Shao showed was the recanalization of previously treated veins, right? How many times, if we do this long enough, we get patients that come back in our practice that have symptoms and they have recanalization. These are patients that may have had thermal treatments in the past. And so trying to get a thermal catheter into a recanalized vein is very, very hurtful to the patient, right? And it's not an easy technical thing to do as well. And so this is where I thought, well, Varithena is liquid. Why don't we use that as a benefit in getting into these, recanalized segments? And so that really got me, believing in this product and using it. One of the other things that was mentioned is that there's a process here. This is chemical ablation. You have to treat it as a chemical ablation modality. You have to have a protocol set. You have to do this a certain way. This is not just injecting, this is not USG. This is not ultrasound guided foam sclerotherapy where you're just a quick in and out kind of thing. You have to prep the patient. You have to elevate. You have to do the necessary steps that are involved with this. And so my case is, just to kind of tag off of Dr. Shao's, is a venous ulcer case as well. But my case is, why can't I get this venous ulcer to heal? Right? I have all the technological tools that are out there, but sometimes these ulcers, they just are very, very recurrent. So this is a patient, a 68-year-old female who came to me with recurrent left medial ankle ulceration. And she was dealing with this ulceration for 6 years, ladies and gentlemen. She saw podiatrists, she saw wound care. She was in the hands of very, very skilled clinicians. She also had some leg and foot swelling, but no trauma. She was very upset. She was dealing with this ulcer. Nobody could figure it out. Nobody could get to the bottom of it. She's a very social woman. She's a part of her local Irish American Association social club. She wants to do the fun things that they do, the dancing, but she's getting to a point now where she's getting depressed. She doesn't want to even go to church because she's concerned that when she's wearing her dress that people are going to see this ulcer, or she's even more concerned about, is it smelly? Is it going to give a foul odor? So this is really affecting her lifestyle. She has a past medical history of a left leg DVT about 15 years ago. She said that she was treated with Coumadin at that time and everything was fine after that. Hypertension, anxiety, but here's the ulceration. And you can see it definitely looks quite painful. It's red, it's left medial ankle, and you can see that there's a secondary one that's forming beneath it. So all in all, very, very uncomfortable and a very unhappy patient when it comes to this. Now again, this is a patient that I had multiple venous ablations performed at another practice. And when I mean multiple, I mean upwards of more than 6 to the same saphenous vein. And so I started with just a simple duplex venous study, and it showed, not surprisingly, GSV reflux along the entire left proximal to distal calf segment of the GSV. The size of the GSV ranged from about 3.5 to 5.5 millimeters, and the seconds were greater than 3 seconds. We also noticed that there were tributaries that were coming off the distal segment of the GSV that were communicating with the base of the ulcer. Now here's the patient again. The clinical findings suggest that there's recanalization of a previously treated GSV in a patient that has C6 disease. Well, what are my options now? Right? What's going through our head here? What are we going to do in a patient like this? Am I going to go ahead and treat that GSV again? Oh, that doctor, she doesn't know what she's doing. I'm going to take care of it now, right? Again, this patient's had this multiple times, this treatment. Or should we just continue with wound care? Wound care is good, right? But should we just continue using wound care at this time, being that it's been waxing and waning? Or do we actually check in the suprainguinal venous system? Now, let's not forget, ladies and gentlemen, she had a DVT about 15 years ago, albeit it was treated, and she says that she's never had any issues after that. Could she have something going on? And so we did a pelvic venous ultrasound. Unfortunately, it was unable to view any of the common iliac veins due to the fact that there was bowel gas, which is a common issue. So we actually have our patients take a gas X the night before in the morning of the scan. It really helps with visualization. And I want you to understand that this is a pelvic venous ultrasound. This is not a DVT rule out. You have to invest in your vascular ultrasound technologists. Invest in their education. There's multiple pioneers out there that have wonderful courses that you should be sending your staff to so they can learn how to do this very specialized ultrasound. But due to the fact that this patient had a high clinical suspicion, being that she had recanalization of the vein, we decided to go ahead. The clinical findings were strong enough to suggest that we should do a venogram. So we did a venogram and we did an intravascular ultrasound. Here's what the venogram showed. So, and for those of you that are looking at a venogram for the first time, what you can see is you're looking at the patient from the ceiling, anatomical left and right, and you see the left and right common iliac veins draining into the IVC. What I want you to pay particularly close attention to is when you notice the dye making its way up the left system, this is the AP and the REO view, you can see that there's collateral branches that are filling. When you look at it initially, you said, oh, that's not too bad. Looks like the flow is good. But it's not until you actually put IVUS in, which should be the gold standard. It's becoming the gold standard of treating pelvic venous disease, outflow obstruction. You can see the IVUS catheter is pulled back from the IVC. Here you can see the irregular borders. You can see finger-like projections or synechia or webbing, which suggests chronic scarring. And again, ladies and gentlemen, this is a patient that had a DVT 15 years ago. She has post-thrombotic syndrome. We know that post-thrombotic syndrome can occur in 40 to 50% of patients that have had a DVT despite them being adequately treated. So please remember that if you have a patient that has this type of symptoms, that definitely consider looking at the venous outflow tract. What did we do? We went ahead and we treated this patient. We put a iliac vein stent in her left common iliac vein, and now you can see that those collateral branches that were filling are no longer filling. This is a good inline flow. And so how did this patient do? Well, I thought it was a hot shot, and I thought at 3 months she was going to come back and she was going to have a closed ulcer, but she came back in 3 months, and I was very, very disappointed in myself. And I walked into the room, I greeted her, and I looked very disappointed, and she said, what's wrong? I said, well, I didn't get it to close. She said, well, I just want you to understand my left leg swelling and foot swelling has gone down considerably. I feel like I want to walk, but yes, I'm bummed that this is not healing because I've seen it heal like this partially and then open back up. And so it occurred to me at this point, we should continue to think outside the box. What other options do we have here? Should I just continue to monitor her, send her back to wound care? Not a bad idea, but should I repeat a pelvic venogram? Could it have been that stent gone down that quickly? I'm not sure about that. Should we repeat a venous superficial ultrasound? Because remember, she had the entire GSV that was refluxing prior to this venous outflow obstruction being treated. But now that we've treated it and she still has a consistent ulcer there, let's check the superficial vein system and see what we find. And so very interestingly, the thigh compartment GSV was no longer refluxing. It was the distal calf GSV that was feeding the tributaries into the base of the ulcer that continued to have reflux. And so what am I looking for in a treatment modality in this situation? What I'm looking for is something that's going to have the ability to penetrate that base of the ulcer into that venous pooling. It's going to also be able to get into a recanalized or scarred GSV because there was pockets of reflux that were noted in that GSV. And again, putting a ablative catheter that's thermal is not going to be easy and probably not very beneficial to the patient. Well, again, that's why we're here at this lunch symposium. Varithena has the versatility to get where most products don't get to, and it allows us then to treat these patients that walk around with ulcers for years and years. I'm not going to go step by step, but for those of you that are not familiar with doing the case, like everybody said, elevate, elevate, elevate. Very important. If you don't elevate the leg, you're not going to allow adequate drainage of that venous system. Thereby, you're not going to have good wall contact of that medication. You really want a good wall contact there. So draining the blood ahead of time will be very beneficial. And like my esteemed panel pointed out, you can get the access before you elevate because life can become harder once the leg is elevated and the GSV starts to shrink. Once we elevate 3 to 5 minutes, mind you, you also have to understand that you don't have to use a sterile pack here. This is also something that I noted during COVID, that with all the shortages that are out there, lidocaine, saline, sterile packs, that you can just simply do this. You have a very nice wedge that is provided by Varithena. And then we went ahead and after we elevated for 5 minutes, we injected 5 cc's into the distal calf compartment, and then we compressed proximally. And why do I compress proximally? Because I want to allow the Varithena then to hit some resistance up north and get into those tributaries that are getting into the base of the ulcer. So how did this patient do it? And then obviously wrap the patient afterwards. Compression is critical. The patient has to be compliant with the compression. Otherwise, the modality won't be as effective as greater than 96%. So we really want to make sure that these patients compress. Take a look at this. At 6 weeks, she comes back. She's so happy. Mind you, this is where she started. And I think that this was a situation where, again, the patient had combined superficial and deep venous disease that really, it was very important for us to think outside the box. So I think, this is a recurrent theme here, but my final thoughts on Varithena is what I like about it most. It's very easy to use once you understand the steps. And please come to any of the training sites across the country that Boston Scientific will be happy to host for you. Versatility of the modality itself, patient satisfaction. Let's not forget, these are less needle sticks, ladies and gentlemen. Most of the time when a patient comes in and you talk to them about a treatment, they say, how many needle sticks am I going to get, right? So you've gone from potentially 5 or 6 needle sticks to maybe 1 or 2. The outcomes are fantastic. They speak for themselves. But again, in tortuous anatomy, recanalized veins, and in C6 disease, I really think nothing can compete with Varithena when it comes to that versatility. So with that, I'm going to conclude my case, and we're going to open it back up to any questions, discussions, or anything else. So thank you so much.
We'd love to hear from the audience of any questions. I have a quick question for you. Well, actually, I'll poll the audience, if I may. It was a great case, Dr. Satwah. How many of you who use Varithena would have treated the recanalized segment of great saphenous vein before looking at the deep system? Don't be shy. Oh, yeah. Sorry, I can't see it. Okay, yeah, I think I wanted to ask, in that patient, although I only saw the ankle portion of her leg, it didn't look that swollen. And I place a lot of iliac stents as well, but usually I sort of look at the picture of if their leg is really discrepant in size, girth, then I say, yeah, let me look at the deep system first. But why not try just getting rid of the superficial reflux? I don't think you burn any bridges there, and to see if it heals.
No, I absolutely agree. But what I wanted to highlight in that case was that this is a patient that prior to coming to my practice had multiple ablations of the GSV and it kept recanalizing. And so I think that if what I was going to do is treat that, and again, I didn't know what modality, that was another thing. If I'd seen that the patient had been not treated with Varithena, then I think that would have been a good thought. And that, hey, let me try this because maybe this will get into those recanalized segments. But being that this patient was C6 and being that, that's the history she showed up with, I thought that in the face of having a DVT 15 years ago that, hey, you know what, this may be a good idea to check. And I'm glad I did. Because, how long has this patient been walking around? So I agree with you. I think that swelling, if we look at swelling as one of the main symptoms, that's fine. But I think we'll miss a lot of disease in patients that have C6 disease, especially with the history of the DVT. So I learned a lot in that case, and that's why I like to share it with everybody.
And I would say that I just treated a patient too that had a recurrent ulcer and really minimal deep venous reflux on the ultrasound. Obviously, if you see deep venous reflux all the way from the iliacs down, you think, pretty simple to use a venogram and an IVUS. But in a patient, even with minimal reflux, if they're recurrent and you've gotten rid of most of their saphenous veins, you definitely do need to look somewhere else.
Absolutely. I think the other debate is that, and we won't get into this debate, but I think people also ask that, hey, if a patient is not C6, if they're C3, like a swelling patient, and they have venous outflow obstruction and they have superficial venous disease, should you treat them both? Should you treat one versus the other? And again, there's many debates, but in my practice, I always go for the least invasive, and that, I agree with you, is treating that superficial venous system, seeing how that patient does, and then after that, determine whether you need to get into the deep vein system to fix the outflow tract.
And I would just add too that especially for left-sided disease that's recurrent, like have a high index of suspicion for May-Thurner or iliac vein compression.
This is more of a procedural question, but I've had multiple patients. Actually, the index patient was a patient with C6 with significant edema distally, and the skin was at risk up until just above just below the knee. And so rather than inject proximally, I placed a needle in a retrograde fashion and injected down because the entire greater saphenous vein was insufficient, and it worked. And so I started doing that on a routine basis now. Has anyone else here have done that, or am I like on an island by myself here?
So we can't really discuss it as panelists as it is off IFU, but
But I appreciate what you're saying about the skin being fragile, because I think that's important. We talk about using a sheath. A sheath is very important when you're injecting Varithena. I think if you use a 21 gauge needle, you're not going to adequately, or you may not be able to get the medicine in the true lumen, because we know as much as anybody else that when those veins, when the leg is elevated, that needle can dislodge from the lumen, and then you're going to have an injection into the tissue, which we don't want. But if you have a lot of fragile tissue, you can use a butterfly needle, 23 or 25 gauge, to really get into that vein without causing too much trauma to the skin. The other thing you have to understand is that this is liquid, right? So when you're injecting, you can manipulate that, right? So you can compress in certain areas. So retrograde, I understand what you're saying, but if you inject distally and you want that medicine just to really hang out in a certain area, you can compress distally and proximally and really get that to clamp down and settle in that area. I don't know what the rest of the panel does here.
that's what I do. These are incompetent valves. So when you push or I guess it will be distally, right? But at the thigh, then if you push down there, the valves are not competent at all. So even a little bit of resistance, it's just going to flow right back. And so instead of sticking them multiple times, I actually just do that as well.
Yeah, I agree with the co-panelists too. And I think Stephen Deek published his series of using Varithena to treat the distal tributaries, where he injected proximally to close up the proximal segment. And then once the proximal segment was closed, he injected further. And the beauty of that is it kind of selectively targets the refluxing tributaries and leaves the competent veins alone.
I just want to mention, I appreciated the comment about, investing in your vascular labs, because we've been doing a lot of pelvic duplex ultrasounds to rule out, compression syndrome and, nutcracker anatomy and whatnot. You get them in, and PO, the gas X is a great idea. Even just kind of shifting them around, putting them in reverse trend and trying to kind of image those vessels. And then if the indication is there, there's doubling velocity, tripling or quadrupling in the diameter, then we can do the venogram. So I really like the approach of, non-invasively imaging it and going from there, trying to get the bigger picture. And I know there's a lot of education out there for the ultrasound technologists to experiment and work at it, to try to hone their skills, because I couldn't do it 4 or 5 years ago, and now I feel like I'm very well skilled in it. So I appreciated that. But I wanted to mention and ask the panel, in terms of the Varithena getting into the perforator veins and getting into the posterior tubules and the gastrocnemius and potentially popliteal veins, what methods do you use to try to prevent that from happening during the procedure? And then how do you typically address it when the postoperative duplex shows deep vein thrombosis?
So I usually map it out with my vascular technologist, and I mark all the reflexing perforators while the leg is down. And usually I access above the biggest perforator that I see in the calf. Now, there are obviously times when there are perforators in the thigh, but I hold pressure. So between my vascular tech and myself, I assume that there should be no more than 4 reflexing perforators with our 4 hands. And we basically just hold pressure while I inject in those areas, and that usually does the trick. And if I do get a DVT, it's most often just in the tibials. And again, when I do see them in the postoperative duplex, I just go by the chest guidelines. If they're symptomatic, I treat them. Most of the time they're not, and I have them follow up with me within a week, and usually with the patient walking as frequently as I ask them to, usually it dissipates. But I do have a lot of patients, interestingly, who refuse to come back every week to get that done. And in those patients, I say, okay, if you don't want to do that, you're going to go on anticoagulation. So that's where I differ in a little bit from the chest guidelines, just because of the fact that I have a little bit of a compliance issue in my demographic.
Yeah, I'll echo the same thing. That typically the most important part is actually the vein mapping preoperatively, so that you find all the perforators. Sometimes when you miss a perforator, that's when you get a tibial DVT. And manual compression works pretty well between the RVT and and just having all your fingers on it as you're doing the injection. And I would say that sometimes we'll see a little bit of foam in the popliteal vein or the common femoral vein, but usually it washes out. Like if you have them plantar and dorsiflex the ankle like 40 times and recheck, usually it'll be gone, and I don't really worry about it too much. I used to worry when I first was starting out, but typically it doesn't cause DVT.
That's very nice. Yeah, the dorsiflex works really nicely because what you're doing is you're contracting that calf muscle and thereby squeezing on the perforator. But again, despite our best efforts, every now and then we'll see that medicine creep down a perforator that you just didn't catch. So obviously it can happen, but mapping is important. In my practice, I call it the rule of threes. If I have more than 3 perforators that are greater than 3 millimeters, I'm nervous about a lot of that medicine making its way down. And so that's kind of my rule of thumb. That's just something I've adopted. But yes, obviously compress. A situation arises every now and then where you have an ulcer and you really want the medicine to get into the ulcer, but then there's these pesky perforators that are hanging around the area. And you're just like, well, how am I going to get the medicine without getting it into the perforator? And so just to share a tip and trick, what I will do in those situations is I will take some tumescent and I'll tumescent down the perforator ahead of time, by increasing the pressure around it, and then I hit some Varithena into the ulcer so I can really get it to hang out there and not worry about getting down the perforator. Just a little trick I learned along the way.
Thank you.
Sure.
I usually just use like 1% lidocaine or something like that in that area. Yeah.
Quick question. You mentioned on occasion you use anticoagulants and patients do not come back for follow-up or when you're concerned about the DVT. But when you use that, doesn't that reduce the chance of closure of the vein you're trying to close with Varithena?
Personally, I haven't found any decreased efficacy of closure, and most times we actually do this if patients are taking anticoagulation for atrial fibrillation. We don't stop it, and I think the efficacy is the same.
Thank you.
Yeah, you don't have to worry about tailoring anticoagulation or anything like that. You don't have to hold anticoagulation. You don't have to worry about if you put them on anticoagulation, it'll open up any of the veins. There's really no direct correlation between the two, in my practice at least.
I agree.
Excellent panel. Thank you guys so much. I just had a question. I use Varithena frequently, and it's so effective that a lot of times I use it when I'm going to pre-treat for my phlebectomies. Do you guys have any tips or tricks for timing for when you would do Varithena versus your phleb, being that if I let too much time go, then all those are sort of coagulated and hard to remove?
I would say it's actually kind of largely replaced phlebectomy in my practice, which is nice. I kind of hate doing phlebectomy. It's kind of a time suck. And I would say that I find that more than 1 week, or like at 1 week, it's actually too organized to really draw it out with the syringe. I'd say optimally, if you're trying to draw it out with the syringe, maybe within 3 days. But even then, I try to avoid phlebectomy at all costs. And I find that sometimes you can simply just nick the skin and kind of express the retained coagulum out, and it works just as well, and you don't have to spend the time and make a bunch of like incisions that you have to close.
I think the one thing that I always tell my patients as well to prevent having to get draining the coagulum plus, the phlebectomies is you gotta wear the compression and what I call the little Rice Krispie things, because those Rice Krispie things really give that focused pressure. And I wrap them pretty tight with an ace bandage and the little, do they have a name? I just call them Rice Krispies.
They're called Robbie pads.
Okay, Robbie pads. So the Robbie pads, I put them on there. And sometimes I have to open up another pack because, just 2 of them really isn't enough, especially if you do those larger tributaries as well. I really like to put extra pressure on those as well. So I think that's really cut down on my need for phlebectomies by using those Robbie pads.
Absolutely. I agree with the panel. I think that, listen, the less time that is spent doing the Varithena and then doing the phlebectomy, the better for the patient. I tend to do them concomitantly in the same session. I don't stage them, just my personal preference, just because I'm worried that, hey, even in a week, if that retained coagulum starts popping up, especially in those big varicosities, then I'm going to be sitting there doing much, much more. So I'm more proactive about that. I agree with the panel that use the Robbie pads. The Robbie pads are basically cylindrical, kind of look like little sausages that come with the Varithena pack. So that is provided to you by Boston Scientific, and they provide very, very nice focal compression along those bulgy areas. Another tip and trick about those Robbie pads is that don't put them directly on the skin, because what we found is that, especially during the heat, they cause blistering. Take a 4x4 or just put some gauze over the skin and then put the Robbie pad on top. That really helps with these patients. But compression is critical, I agree.
Thank you.
2 questions. The first question is there an update on the maximum amount of dose used? Because lots of good patients for Varithena are large, tortuous GSV, ASV, and it's just not feasible to wait. And then if you wait, you allow more for phlebitis to happen. So it's actually you're hurting the patient when you're respecting the 15 ml rule. So if you have any update on that, and taking that question, I want to know if there's any updates on gastroc DVTs, because it tends to be this is where I'm struggling the most, not much with the perf because I can't see the perfs. So I'm looking on ultrasound where the foam is going. But those gastroc DVTs, is there any data on the amount of Varithena given and any correlation? And I agree with the approach of asymptomatic gastroc. I usually follow them 2 weeks and they never cause any problem. They're most of the time asymptomatic, but it's still something that I do pre-counseling on when I'm pre-counseling my patient on what method to choose, because they need to know that so they don't have surprises when the vascular tech scan them.
Yeah, the IFU is 15 mLs injection per session. As far as gastroc DVTs, I really don't lose much sleep over it. I mean, I tell patients that there is a few percent of patients that may get a tibial or gastroc DVT, but I actually just treat them with anticoagulation. I just keep in close contact to see if there's any problems, and I've never lost any sleep over it.
Yeah, same here. I mean, I think that surveillance is important. I think that patient education is important. Like you said, spend time in the consult letting them know that, hey, just like any procedure, there's some risks that are involved with this. And if we do, fall into a case that you do develop a DVT, most likely it'll be below the knee, and we can treat it if it needs to be treated. I follow them. Gastroc DVTs, I see some of those as well. I don't think, again, you should lose any sleep over it. They're very, very, innocent for the most part. Even if you put them on a low dose aspirin, what I find is that these behave very differently. The thrombotic nature of them, they dissolve quite quickly, to be honest with you. I don't think I've ever had to put anybody on any oral anticoagulant for longer than 30 days. Most of them will dissolve. What is the panel's experience there? Yeah, exactly. The other thing I want to mention is that for follow-up protocols, this was a hard thing that I learned along the way is that when you bring these patients back after treatment and you check, usually everybody brings the patient back at 1 week to check for DVTs within a week. You don't necessarily want to check for vein closure at that time because the studies showed, VANISH-1 and VANISH-2, that these patients were brought back at 30 days for assessing vein closure. So if you bring these patients back in 1 week and the vascular tech goes, hey, doc, it didn't work, the vein is still open, don't be so hard on yourself. Give it the 30 days, then bring them back, and what you'll find is that your closure rates will go up significantly.
And I want to know your opinion on the volume. Have you ventured above 15 ml or you guys?
I don't venture, and I'm very adamant about draining the leg before I inject. And so I don't think you need to use, even if I treat both the ASV and the GSV like I did in my patients, I don't think you need the 15 mLs. I just split it up to, 7 and 7. I inject very, very slowly while the leg is up. I mean, you could barely see the vein by that time, and let the microfoam really react to the vessel wall and just be a little bit patient with it. And I don't think that you need more than 15 even for 2 veins.
So sometimes if you have like pulmonary hypertension, right heart failure, obesity, sleep apnea, those are very difficult to collapse vein, even with the elevation, like 50 degree. I do sometimes use tumescent to try to make it smaller, but there are those patients where the veins do not just collapse nicely. It's not just a textbook.
Yeah, and I agree. And that might not be a patient to use Varithena on. I mean, that might be a patient to use some other modality.
Like surgery, send them to vascular surgery when they're like tortuous, inaccessible with the laser. That's what we're doing sometimes.
Absolutely.
Going back to the DVT, I was wondering whether the DVT is caused by the diastolic reflux into the deep system. And if that's the case, then if you start the Varithena from the top and come bottom, then you eliminate the diastolic reflux into the deep system. Is that something that people have looked at?
I mean, I don't necessarily think it's diastolic reflux getting into I think it's incompetent valves, right? Which is causing the disruption physiologically. As far as treating the GSV, what I typically do is I do treat it proximally first, and then in a situation where the entire GSV is refluxing for a couple of reasons. Number one is that if I give 10 cc's at the ankle, then by the time the medicine makes its way up to the proximal segment, it's going to lose its potency. So what I do is I'll split the difference. I'll probably use about 5 cc's in the thigh and 5 cc's in the calf. The other reason why I like to do it in the thigh first is because it causes spasm. When you do enough of these, you start to notice on the ultrasound, it's really neat as the medicine's making its way through, it's causing the vein to spasm. So what you do is when you cause that vein to spasm in the thigh and then you inject distally, you've created a very nice safety check so that medicine is not going to venture up too high. It's going to have a nice resistant column up north. So that's why I do proximal and then distal second.
So I think that that's great, because I was just going to say, as you have to inject it at a speed of which it moves up. And if you do it a little bit too slowly, you're going to basically occlude a portion of your GSV, and the more you push, the more it's going to kind of come back, which in some patients, especially ulcer patients, that's okay. But at a certain point, that pressure might overcome your competent perforator valves. And that's something that I've seen a lot. I have to really tailor how fast I push it in. And the fact is that I have to wait till the foam gets to the saphenofemoral junction before I start pushing. Because if you don't, like I said, you're going to increase the pressure and you're going to keep pushing against resistance. And instead of going down the great saphenous vein or the anterior accessory vein, you might push it through what used to be your competent perforator into the deep system. So you have to be careful about that.
So that's an antegrade push. So how about a retrograde injection? So you're pushing it antegrade towards the flow of the vein. But how about a retrograde push? Again,
when you're pushing from above, I think these veins are pretty incompetent. The valves are pretty incompetent. So I do think it will go down. But I don't know, what do you think?
I'm trying to understand, are you saying injecting from the top, or are you saying holding from the top?
So you advance a catheter to the saphenofemoral junction, and then you start where you want to start and then come back.
We don't inject through catheters. We just inject directly into the vein. We don't have any catheters or anything like that. You just put a sheath in and you inject right through the sheath.
So what if you put a catheter and inject? Will it mitigate the risk of DVTs?
I can't say I've ever done it. I don't think it's on label.
Yeah, it's not kind of the standard way that we would do it, but yeah.
I don't think there's a reason to do it. I think the closure rates, are very good without having to put a catheter in anything. I'm an interventional cardiologist. I love catheters, but I don't think it's necessary in this situation. I think that as long as you get the medicine to contact the wall of that vein, and like Dr. Kiguchi said, be patient. Let that medicine, it's going up that vein. So just because it didn't get there doesn't mean you didn't give enough. Just give whatever set standard you like. And again, that's an art too, right? Not everybody's going to get 10 cc's. Some people will get 6. Some people will get 5. So I think that just comes with the adaptation of becoming more comfortable with the medication.
Yeah, I agree 100%. I think you'll get a comfort level after you do the first few cases of how much you need to inject. It's about the vein diameter. If it's once you've elevated the leg and compressed it and it's a tiny diameter vein, you really don't need much, but it is important, I'll echo what Dr. Kiguchi said, to follow that foam up with your RVT or your ultrasound. Because you don't want to compress right away because you need to have some venous outflow for the foam to make it up to the junction.
Great. Thank you so much for all of your questions. I hope that everyone's learned a little bit about Varithena and in our practice, how we use it. I think for my practice, and I think for everybody here on the panel, we really like its flexibility and being able to get through tortuous veins, recanalized veins, and as well sort of the below knee segment, basically all of the things that catheter-based endovenous ablations cannot do. So we thank you for coming and for Boston Scientific for sponsoring this lunch symposium.